And as I said, my name is Margaret Fitch. I am a professor adjunct at the Faculty of Nursing at the University of Toronto, but currently am overseas doing workshop and student work in. So if I disappear, don't panic. Sometimes the internet does go off here. But let me introduce our speaker for this morning at your end. Jacqueline Galica is at the Queen's University as an associate, a colleague of mine in nursing, and she has been doing some wonderful work in terms of engaging patients as partners in cancer research. And I think this is an area that we're going to see more effort, more requirements to actually engage patients, and how to do it well is something we all could benefit from learning. So I'm delighted that Jacqueline is with us, and I look forward to your presentation. We will have a Q&A as long as there is time before our hour is up, so you all can think about your questions as you're listening to Dr. Galica.
Thanks. Thank you, Mark, for that introduction. And thank you all for being here. And I'm really excited to be here and talk about a topic that's very important to me, dear to my heart, and share with you what my team has been working on over the last few years. It's been really exciting. It's been really challenging. And I'm going to share with you some of what we've been doing and some of our learnings from that. So like Dr. Fitch said, I am a registered nurse. I am a certified oncology nurse and associate professor at Queen's University, which is located in what's known as Kingston, but on the traditional lands of the Anishinaabe and Haudenosaunee. So I'm thrilled to be presenting from those lands to you today. So just a few topics to guide our conversation today, and I would like it to be. I would really like to hear some dialogue from the audience in the Q&A, but really, just first off, to start off, what is patient engagement in Canada, and just situating that as our context for where patient engagement has been over the last decade or so. Then we'll move into sharing one researcher's experience with patient engagement in cancer research, and really that should be one team's, because I'm here as the researcher presenting on behalf of really a team's efforts of work that was being done over the last few years. And lastly, I just want to end off with a few resources for patient engagement for researchers interested in learning more, some of the resources that I frequently draw from and that can be useful within cancer research and beyond. So let's move into this first agenda item, and this is not going to be an exhaustive, detailed description of where patient engagement has been over the last little bit more than a decade, but instead just to provide a higher level of overview of how patient engagement as we know it now, how it's come to be. So really this document, Canada's Strategy for Patient-Oriented Research, was really one of the first in 2011 that was launched to start the ball rolling, so to speak, with patient engagement in research. It was referred to as patient-oriented research, and there are some other terms like patient engagement, and we'll talk about the various terms in a little bit. But this work was really started by CIHR, who's really paved the way for patient engagement research as we know it in Canada. And this work started in 2009. And they started to draft their health research roadmap, and it outlined their strategic directions over the next 5 years. So they put together an advisory board from across Canada and had consultations with a number of different groups, such as universities, academic health organizations, industries, health charities, federal, provincial, territorial governments, as well as Health Canada. Really, really diverse consultation. Also deployed some surveys to get some feedback, and from all of this was reviewed And what they really found was there was a particular need to better reflect the patient perspective. And so this is how it was launched. So there were three needs identified, that patient perspective as the first. There were regional differences and needs clearly identified, but as well as stretching the breadth of healthcare disciplines and settings. So what were the solutions that this strategy had put forth in 2011? The first was to develop a talent pool. And so this was through training and strategy awards to build capacity for patient-oriented research. The second was to increase funding, specifically to support well-designed research that address issues that are relevant to patients as well as the care that they receive. The third was to focus on patient-oriented research networks. So starting up these clusters that could identify priorities, develop protocols with scientific oversight in research programs. The fourth is building of the SPORE support units that we know of across Canada. Each region and or province territory has one, as well as develop guidelines, disseminate the need for patient engagement or patient-oriented research in order to promote the uptake. So a lot was in that 2011 document. And there have been other documents produced since, but this is one that I often refer to that was published in 2014 by the SPORE. It's the Patient Engagement Framework. And really, it was designed to establish those key concepts, the key principles, and areas to be adopted for persons working within the SPORE networks. And again, this was developed through a consultation process with patients, but also patient engagement experts. So what's in this document? Well, I find it useful for some of those concepts and those definitions that are listed. The first is patience. And so I think this persons on the call here will appreciate that patients is not only the individuals with the experience of the health issue, such as cancer, but it's also their informal caregivers and their family members and friends. So this is a broad encompassing term of patients, and it really is acknowledging that these patients, they have this perspective, this expert perspective based upon their unique experience as well as their knowledge gained through living with the condition, such as cancer, but as well as their experiences of navigating the healthcare system, treatments, and such. The second term is patient-oriented research, and I see this as sort of this umbrella overarching term. It's a continuum of research that engages with patients as partners, focuses on patient-identified priorities, and it's intended to improve patient outcomes. And so this is really done with multidisciplinary teams that have partnerships with policymakers and other knowledge users, and it aims to apply the knowledge generated into improve healthcare systems and practices. And so this is why I see it as this overarching umbrella term. Whereas patient engagement is more specific, it's that meaningful and collaborative collaboration. Sometimes it's in governance, or it could be in priority setting. It could be conducting research, helping support the knowledge translation. And so it could also depend on the context of the patient engagement. Sometimes this is a person bringing the perspective of an entire community of persons. But it's understood, it's well understood now that engaging with patients in research has shown that involving them early in the design process is the most ideal and leads to best results. So what are some of the ways that patients could be engaged in research projects? Well, the first could be in governance setting. This could be identifying, do we need an advisory board? Should there be some sort of consultation process? Is there going to be a smaller group that does the heavy work of the project, and then a larger extended group that's consulted as needed? What does that governance look like? And patients can help with that. Of course, they can help develop research questions. Based upon researchers, what we read in articles, patients have that lived perspective again, and that can help nuance, and together there can be this ideal research questions posed for a research project. Patients can help us improve access to patients via networks. And so via those networks, they could bring conversations that they've had with other patients to inform the research questions, or it could be useful to help collect data. Who are the networks of persons that we should be collecting information as research participants from? Patients can be instrumental in helping us evaluate the results. Us as scientists or researchers, we're looking at with one lens, but what's the lens of the patient, and what do these results mean from that patient perspective? Might be different than what we see as researchers. And of course, this last purple point gets back to the patient networks. How do we best share the findings of our project? Who needs to hear about the results? Who could benefit from hearing our results? How do we get the message best to those people? Patients can be really helpful to tailor that message. And so moving into my team's experience, what formally we've just talked about some foundational, where patient engagement has been in the last 15-ish, 13-ish years, but what's been our team's experience with patient engagement? And so I didn't say much about myself, but I had a decade of clinical oncology nursing experience before leaving clinical practice to pursue a PhD. And this was all my clinical practice and my PhD were all completed in large urban centers. And I wondered about other centers that may not be so well resourced as the urban center where I was. And so my PhD focused on fear of cancer recurrence among cancer survivors, and my postdoc also followed on that topic. But the paper that I have here on the screen is the paper that stemmed from my postdoctoral research. And this was about exploring how ovarian cancer survivors were coping with fear of cancer recurrence. And we were particularly interested in those ovarian cancer survivors who were living in small urban and rural settings. And so we did a qualitative descriptive study. We did some focus groups because some persons lived quite a distance away. We did some telephone interviews with these persons, and we did answer our research question. We answered how they were coping with fear of cancer recurrence. But what was really, really interesting to me, and I think is relevant that I want to share for moving forward with this conversation, this presentation today, is that most of the participants said preparing for the future. They believed if they had been better prepared about what to expect after treatment, it may have lessened their fear of cancer recurrence. And so although that wasn't the primary answer or the primary research question we were exploring, it really spoke volumes to me as a nurse, and remembering those conversations with patients and families in my clinical practice, it spoke volumes to me that this was an area of need, and an area that nurses could research and fill that gap. One of the things I wanted to share with you, one of the quotes from one of the participants, they all identified as women, and so this woman said, "I felt cut off, and then now what? Like, now what? You've been there," meaning the cancer center. "You've been there for 4 months, and they've," meaning the clinical team and patients there, "they've been a part of your life for 4 months. And then what happens?" So this is just one quote that illuminated that preparing for the future. In this project, I asked participants if they would be interested in working with me in future research projects. And participants had the option to participate in this project and or not give me their name to keep for future research. But one of the participants who was very vocal in the focus groups was a woman named Kathy. Kathy was an ovarian cancer survivor. She had a lot to say, and she did consent for me to reach out to collaborate on future research projects. And so I did. I reached out to Kathy and talked to her about, this this finding that I've just shared with you. And we began to strategize, what could we do to meet this need that was clearly identified by the women in the focus groups. And so Kathy and I put our brains together, and we put together a project, like a stage of series in a project, and we've just had it published just this year in the Canadian Oncology Nursing Journal. You can access the QR code there. But Kathy and I, over a period of a few months, we decided we needed to have a team. We wanted to see what else. We didn't want to reinvent the wheel, so we wanted to see what was out there. We wanted to draft some sort of resource. We didn't know if it was a program or whether it would be some sort of booklet, so we just landed on the term resource. But of course, we wanted it to be useful, so we wanted to not only draft it, but we wanted to test it, and of course, we wanted to share it with people who could use it most. And so these are these 5 steps I'd like to elaborate with you a little bit in the following slides. So Kathy and I were co-principal investigators on a CIHR SPORE application, and we were successful with our team. And so this was the very first step, even before applying to CIHR. We put together a team because we knew from the research, and we knew from our own work experiences, that those multiple perspectives that are inclusive and relevant to the development of the project goals are essential. So Kathy also believed that the project, the resource that we were working towards, needn't only be relevant for ovarian cancer survivors, that it could probably be more broadly useful to gynecological cancer survivors overall. And so we decided to broaden that. And so Kathy was the gynecological cancer survivor on our core team. Myself was a psychosocial oncology nurse researcher. We were fortunate enough that we could have research assistants funded through the project, but then we also had an advisory team who was more tangentially, more like a consultation, and I'll talk about their role a little bit in the next slides. But we had 2 other gynecological cancer survivors, but as well we had 4 clinicians, 2 medical oncologists, and a nurse practitioner who worked in gynae cancer care, but as well as a social worker who worked more broadly in the psychosocial oncology program. And excuse me, I'm just going to have a little drink here. There, thank you for that. So after we had our team, we had received our funding, like I said, we didn't want to reinvent the wheel. So we looked at the literature, and we did a scoping review. We wanted to look at anything and everything that was known about the needs of gynecological cancer survivors at that end of primary treatment. And so this scoping review, we had about 71 papers that we sifted through. And Kathy was involved, maybe not in the screening. We had our health librarian do the search. We had our research assistants and myself do the screening. But Kathy was heavily involved in making sense of those results and how did those results come together. And so we did synthesize those results into 7 different needs that are found here on the screen. Physical needs, sexually related concerns, psychological and emotional well-being, altered self-image, social support needs, supporting the return to work, as well as navigating the healthcare system, challenges and preferences for navigating the healthcare system. So as we put together these results of this scoping review, we shared it with Kathy. We also shared it with those advisory team members who suggested to the core team, the research assistants, myself and Kathy, who were doing the heavy lifting, so to speak. They thought that these results should and could be presented as some sort of model to guide discussions at that end of treatment transition. And so we put together this document, has some little check marks of topics for clinicians and patients to address or speak to at the end of treatment. But really, all of these needs are interconnected. And so that's what we tried to indicate in the model, that they're all have a role, are intricately connected in post-treatment needs of gynecological cancer survivors, but they're all set on this backdrop of healthcare preferences. So we did have this published, admittedly for a clinical academic audience, but now we wanted to move forward with that resource, that gap in care that we had identified. So we took those results from that scoping review, those domains or those dimensions, and we drafted a resource. And you can see here in the middle of the screen that each of those domains were set into a chapter. So you see physical health, emotional and psychological well-being. Those are the domains from the scoping review that we found. We put them into to a patient-friendly booklet, and you set it into with an introduction for survivors, the how to use the guide, that not necessarily every chapter may apply to them. For instance, some people may not be returning to work, and instead to use the chapters as it was relevant and as they needed. But caregivers also, we heard also that caregivers wanted to know that this resource was useful for caregivers to understand what their partner or their loved one was going through. And so we structured the introduction for how caregivers could use this resource, but how patients could use this resource as well. So I'll share with you, the next slide is just giving you a glimpse into this resource. And so this is the typical structure of how each chapter begins. You see, this is the physical health chapter, begins with a short little introduction of what is physical health and physical health needs in the context of cancer survivorship. There's a little bit of specific content, the types of topics, types of symptoms that people may experience. People are encouraged in the introduction that not every one of the symptoms they may or may not experience, but these are the types of symptoms that people could experience. We included some quotes. You see a couple of quotes here. I don't know where my mouse is, but I don't know if you can see my mouse. We include some quotes. These are from the qualitative research papers that that were included in our scoping review. And this is just to help normalize. I heard in some of that postdoctoral work that sometimes people felt like they didn't, and this is true from the transitions survey, the National Transitions Survey, sometimes people didn't know it was normal, or sometimes people didn't know what to expect. And so our goal was to try and help normalize and promote this sort of conversations. You see here, we also included some reflection questions for patients and survivors to ask themselves. Is this something that I should be asking my healthcare provider about? How should I go about asking my healthcare provider about it? You see there's lots of empty space. There was, on the next page would be some note pages, but our intent was just to make it useful, easy reading, and informative. So after we drafted this draft resource, we called it, we shared it with our advisory team. So this was the other group of gynecological cancer survivors and our clinician team members, and we had them look at it. Had them evaluate it for what was the content like? How did they see the usability? Did they think it was useful for us to move forward into some sort of testing? And so they all provided a little bit of feedback of how it could be improved, but then we moved forward into the testing of the resource. So how did we do that? Well, we did it in 2 rounds of data collection. So we recruited gynecological cancer survivors, but also their informal caregivers from our our local cancer center, and we tried to be diverse with gynecological cancer survivors represented, and where they were located across our region, not only within Kingston, but in the area around Kingston. People had to have completed primary treatment for gynecological cancer in the previous 5 years, and so they were invited to participate in our study. So in the 2 rounds of data collection, participants received the drafted resource in their preferred format. Some people wanted a hard copy, some people wanted electronically, and so we met their need and shared the resource with them that way. They had 2 weeks to review the resource and prepare any feedback or suggestions for refinement. And to guide their review, we asked them to think back to their own experiences at the end of primary cancer treatment and if how the resource would have been useful to them at that time. We also asked them to consider if there was any content missing based upon their experiences. Then we met with participants in a focus group or one-to-one telephone interviews. We met with survivors in a focus group and or interviews, and all of the caregivers were working, so we needed to engage in one-to-one telephone interviews with the caregivers. And so Kathy, my patient partner, was involved in the drafting of the focus group questions. She was involved in attending and administering the focus group questions. And then after the focus groups, we transcribed those interviews and focus group audios, and we did a content analysis for the types of feedback and suggestions that patients and caregivers had. And we assembled all of these suggestions into a list of topics to be considered for inclusion. So we used a content validation process. And so that's what you see in the middle here. You see that we had it structured in a letter. Dear so-and-so, we've received suggestions from focus group participants on the draft guide intended to support survivors and their caregivers for life after primary treatment for gynecological cancer. Given your personal and our clinical research expertise, so these were our advisory team with gynecological cancer lived experience, but as well as clinical experience, we would like to ask you for your opinion about the relevance of each suggestion we've received. So and then we shared with them the most recent version of the guide. We asked them to review each of the following suggestions for relevance to the intended purpose of the guide at the end of treatment transition. And so we asked them to rate each suggestion. If they would rate it as a 1 if the suggestion did not apply to the intent of the guide. They would rate it as a 2 if the suggestion had some relevance to the guide, but it wasn't a critical change, maybe add a little, like a sentence or 2 or a reference. Or they would rate it as a 3 if the suggestion is critical to the intent of the guide and a change is needed. They were also encouraged to provide a rationale for their recommendation. And just to give you an idea, there were 7 suggestions, and we listed the suggestions on this document. And you see this first suggestion was that some participants suggested that end-of-life issues should be included along with strategies and resources to plan for death. So information about MAID, palliative and hospice care. And so considering the intent of the guide, they rated what was their level of importance with this suggestion, 1, 2, or 3. And so after our advisory group had completed this, had each completed this, we averaged the relevance scores for each of the suggestion and topics with an overall average of 2 or 3. They were incorporated into a revised version of the resource. So we made those revisions into the resource, and we did a second round of data collection. And so again, we sent this revised resource with a description of where the revisions were to the participants again. They again had 2 weeks to review the resource and think back to their own experiences. And really, we did another set of focus groups and interviews, again with survivors and caregivers, the same survivors and caregivers. And really, there was very few pieces of feedback. Excuse me. There were very few suggestions for feedback. And so maybe we didn't do another content validation process. So There were very few suggestions incorporated into the final version of the resource. Excuse me again for that. This is the time of year where this cold is going around. So we had drafted this resource, we had tested this resource, we had revised this resource based upon what persons with lived experience had said. And so what were Kathy and our team going to do? And so our intent was really to fill this gap in care. And so we began to decide, how are we going to move this forward? And so we wanted to get it in the hands of patients. And so we wanted to make sure there wasn't any technological jargon, healthcare jargon. So we shared it with a plain language editor, and who reviewed the resource for readability, content, grammar. Revisions were intended to only simplify the language and ensure grammatical correctness, but no changes to the resource's content or meaning. But we did also begin to share our processes in academic presentations, healthcare conferences, as well as publications. But keeping with our initial intent, how to move this into the hands of people who could use this, gynecological cancer survivors and their caregivers, how could we get it into their hands? We started speaking with patient education groups at our local cancer center, who connected us with the larger patient education group, network of Cancer Care Ontario. And so I'm so thrilled that Cancer Care Ontario has adopted this resource as useful to support the end of treatment transition for gynecological cancer. They have actually they are preparing 2-page fact sheets for each of the dimensions, each of those chapters included in our resource. And we have posted the full resource on the Queen's School of Nursing webpage. You can find it under the research section. It's right here. But the option for CCO to adopt them as 2-page summary sheets was to comply with the Accessibility for Ontarians with Disabilities Act. So this is something that our team did not consider in drafting the whole entire guide. But CCO and our team thought this would be the best way to make the guide useful, publicly available on the School of Nursing website, but then also have these fact sheets within the cancer centers so that people could get the content. You can see the content is very similar. There's a little bit of an introduction to, in this case, sexual health. What are the types of sexual health concerns people may experience, types of questions to talk to healthcare team, talking to partner, some supportive therapies. And then if people wanted more information, there is the link to the full resource that's on the School of Nursing website. So we're really excited that we're reaching clinical audiences, academic audiences, but we're most excited that this is getting used and adopted into clinical care. So, after we throughout this process, we've been reflecting on our time of working together, and really this has been about almost a 4-year process that I just described to you in the last few minutes. But we reflected on some of our challenges and learnings, and I think there are 2 main key learnings that we would like to share, and we've shared in the Canadian Oncology Nursing Journal, published earlier this year, is commitment and communication. We were committed to a mutually defined goal that stemmed from the lived and clinical experiences that was this gap in cancer care, and so we were committed to seeing that gap filled. But there was a diversity of people on our team. Some were working full-time, some were retired, some were from healthcare language, some academic, some business backgrounds. So this all added to the complexity, the richness, but also the complexity of navigating and those diverse perspectives, as well as availabilities. And so Kathy's idea right at the outset to have this governance of who was responsible for doing what and when were they involved, that was really, really seminal and important for us to continue to draw on throughout our time of working together. The second key learning is this point about communication. And so having it was really important for us to establish spaces for thoughtful and respectful dialogue, and to also have those clear role expectations. Um, Kathy's background was from executive level strategic change management. And so she drew on projects developed using rigorous and fast-paced project management methodologies and change management frameworks. And so in this discipline, processes and pace was very different than in research processes and pace. Also, the language was different. And one particular example from our experience is the term dissemination. So the graduate student who were research assistants and I were talking about dissemination and how we had started moving forward with our dissemination plans. And all of us on the call think of academic presentations or preparing a manuscript or doing a presentation with colleagues. But for Kathy and her business and change management background, dissemination actually means like the deployment, the printing and the deployment of the resource. And so that's where her head immediately went when we started talking about dissemination. And so there was this bit of tension that some of the teammates were moving ahead without the other teammates being involved. And so you can imagine that clarifying that, those ensuing conversations required some careful listening, very respectful tones, and lots of time to really understand each other's stance in relation to the conversation that was being had. And so, we got better at this. So as time went on, we were more easily able to recognize each other's various tones and perspectives, and could be more easily alerted and discuss that as time went on, but taking a lot of time and careful conversations. And so this last section is just where can we learn more? What resources are out there for patient engagement? And I've talked about where this initiated with CIHR. They do have lots of patient engagement newsletters. They have patient videos about their experience in patient engaged resource. This newsletter, it's about ongoing projects that are engaging patients with research, updates about these projects. We shared with our project in this newsletter, so it's a great way to learn about what's currently going on. Of course, there's the SPORE units that are across our country, territories, provinces, and regions, where we can tap in and learn about and get connected there. The SPORE Evidence Alliance, this is a resource where knowledge users could pose questions based upon their experiences in the community, in clinical practice, what have you. And this team does evidence syntheses. Much like we did with our scoping review, this team puts together evidence syntheses to address those research questions posed by the community. But what about cancer specifically? Well, CCS does have resources for researchers, also resources for patients. There's videos of patients' experiences here. I know CCS hosts a community of practice for people who are involved and interested in patient-engaged research projects. They're actually submitting abstracts to CANO and CAPO this year. So if you want to know a little bit more about this community of practice and you'll be at CAPO or CANO, be sure to check out that to learn a little bit more about that community of practice. But CCS also also has a patient engagement strategy. And so for some of my current patient engagement work, I reached out to them, and they have like a listserv of people who are interested in of persons with lived experiences with cancer who are interested in partnering. And so I was able to connect with some new patient partners that I hadn't worked with before through that strategy. Another model of patient engagement is Canadian Cancer Trials Group. They have patients involved in identifying researchable topics, protocol development, and throughout. And BioCanRx for researchers more in the immunotherapy space. They do have a patient engagement learning institute and connecting with patients. And so these are just a few examples of groups that have formalized models or structures for connecting patients and resources. But as I've just explained to you, not to ignore the organic relationships that can develop through research connections, such as the one I've described with Kathy. I also have another patient-engaged, a SSHRC-funded project where one of my clinical collaborators had a patient in his clinical practice who engaged with us and was a partner with us on a research grant. There's patient engagement networks across different organizations with that are doing this sort of work, connecting patients at institutions across our country. There's also Patient and Family Advisory Council, or PFAC groups. That would be a great place to tap into to identify patient partnerships. So with that, I hope that we've been able to cover some ground, exploring where patient engagement has come from within the Canadian context, albeit at a high level. I hope you've appreciated my team's experience with patient engagement in cancer research, and maybe left you with a few nuggets for learning a bit more about patient engagement models or the organic means as well. And with that, I want to thank you for your attention, and I welcome your thoughts and hearing about your experiences.